Right. Well, do see numbers going up just a bit, so maybe we'll give it one more minute before we officially start the webinar. But thank you everyone who is already in attendance. Really excited to have a diverse group of attendees as well as panelists join for today's session. All right. Well, since we are 2 minutes past 10, I will get us started and have maybe a couple more people join as this session begins. But I just want to welcome everyone to today's session. Good morning or afternoon, evening, depending on where you are joining us from. Welcome to today's webinar, How to Conduct Ethical Research on Female Genital Mutilation or Cutting, Finding Contextual and Compassionate Practices. For those who I'm new to, my name is Olivia Harris. I'm one of SEO's training and technical assistance coordinators and will be helping with introductions and transitions for today's session. We are just wanting to review a couple of quick housekeeping notes before we get started. So you may have seen a notice that today's session is being recorded. We are recording the session and slides will be circulated to everyone who has registered for today's session. So don't feel like you need to actively be keeping track of notes, although we will be having an active chat and sharing resources throughout today's session. We do have a Q&A box that folks have access to during today's session where you're able to submit questions, and we'll also have a closing poll at the end for feedback as well as an introduction poll as we're getting started today. We do have a broad topic, so we might not have chance to address every question that's coming into the chat, but we do encourage folks to participate in that way, as it can also inform kind of future programming and the direction that we can go with any follow-up or resources that we share after this webinar. We do also have live captioning available within Zoom. So if you navigate to the toolbar at the bottom, there is a captioning option for folks who are interested. And because this is a webinar setup, attendees are currently in listen only mode. So your video and audio are not shared. So you won't need to worry about privacy concerns in that way. On to our next slide. I also just want to begin with a disclaimer because today's session will involve discussions of female genital cutting or mutilation, which can be triggering for some folks and include discussions or personal testimonies that could be emotional for participants listening in or folks who are reviewing content afterwards. So we just want to acknowledge that and offer that these conversations are really important to understanding the complexities of FGC and the activism against it. And we know that it can be challenging to hear, and we just request that folks who are engaging kind of take the space that they need to. And we also know that we have a diverse audience in today's session. So for our panelists, we also ask that you define terms as you go, or kind of give context for folks who might be new or unfamiliar to the space as well. All right. And just by way of overview, I also want to offer our agenda outline so you can budget our time for today. We are hoping to spend just a quick 15 minutes or so on our welcome and introduction so you can learn more about SEO, our panelists, and the topics that we'll dive into. But we really hope to spend the majority of our 90 minutes together with our moderated panel discussion. And again, we know that there might be loose ends or opportunities to dive deeper into topics that are introduced today. So we are really encouraging folks to give us feedback in our closing poll so we can understand feedback for today's session, as well as get notes on what people are interested in terms of follow up. And then in regards to our panel discussion, just what you can expect, we are going to hopefully have more of a free flowing conversation. So we will kind of uh, select a couple or an individual to address one or two of the questions. But if there are ever responses or threads that any of the panelists want to pick up on, you are definitely welcome to do so, or to contribute in the chat if that is more effective for you. All right. And then for our attendees, I do want to introduce just our quick introduction poll. Like I mentioned, we're really interested to hear how folks got connected to this webinar, as well as kind of your orientation coming into the session. So I'm going to share 3 questions or open our introduction poll. It should be launched now, and it will just offer an opportunity for you to give feedback on how you heard about the event, maybe what you're hoping to take away, as well as your orientation. So, what is your role, or how are you coming to the space? And I will keep this up just for a couple minutes. I see people are already starting to vote. And I will keep the poll open for anyone who's still going through the questions, but I also just want to introduce SEO for anyone who is unfamiliar or maybe new to the organization. SEO is the host of today's webinar and is an organization that formed in 2015 around advocacy from a collective of South Asian and other survivors of FGC, also known as female genital mutilation, to address the lack of acknowledgement of FGC as a form of gender based violence and child abuse impacting US women. And SEO empowers underrepresented communities to advocate for their inclusion within FGC disclosure and support them to create systemic change to end the centuries long practice. SEO utilizes collaborative grassroots campaigns, storytelling techniques to train communities and lead change. And SEO partners with frontline workers, including healthcare providers, to create culturally sensitive systems of care for survivors within government to address policy level change. And so the work of the organization includes storytelling, but also training and technical assistance work and events like today's webinar. So just wanted to offer background for anyone who is new to SEO and to orient you to the host of today's session. And with that, I want to pass the floor to our moderator, who is Dr. Huda Syyed. She has been wonderful in supporting the buildup of this webinar, but is also the originator of today's conversation. So I'm really excited to pass the floor to her and have you learn more about her background, as well as how she came to this work.
Thanks so much, Olivia. So I will be your moderator today. And before I start, I'd like to start with acknowledgements. I acknowledge the traditional owners and custodians on the land on which I speak today, the Wurundjeri Woi-wurrung and Bunurong people of the Eastern Kulin Nation, and I pay my respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people here today. So there is no shortage of ethical guidance on this topic that we're all gathered for here today. And the World Health Organization has published standards. Every university has a review board, and researchers still keep arriving in the field underprepared, unsure sometimes, and sometimes also a little anxious what this subject actually asks of them. And this is something that I faced during my PhD as well. For me as a researcher, those questions emerged through my doctoral research, which took 3.5 5-ish years, 4 years. And I completed my PhD at Charles Darwin University and explored the topic of female genital cutting using a Pakistani lens and a qualitative method with reflexive thematic analysis. And as I spent time listening to women and navigating difficult conversations, I realized that ethics extended far beyond an ethics application. It became about relationships, about trust, about positionality, identities, cultural context, language, compassion, and responding thoughtfully to unexpected moments that arise in the field and in conversations, or even when you're having chai or tea with women and speaking to them. And that journey continued through my research papers on intersectional feminist research and navigating ethical uncertainty beyond the ethics board in a setting with political and religious precarity, as well as a blog reflecting on why context and compassion are essential when researching FGMC. So, our hope today is that the discussion moves beyond viewing ethics as simply a procedural requirement and instead it explores it as an ongoing practice. And we hope you'll leave with practical strategies for conducting contextual and compassionate research, insights into working across diverse cultural and religious contexts, and ideas that support both emerging and experienced researchers. And we've deliberately built a diverse and distinguished panel, and we will begin with a few grounding questions for all panelists to answer. And we also hope that you folks will also jump in when you'd like to and also contribute. And I'll begin with introductions. Sean Callaghan is the head of research at Orchid Project and is completing a PhD at University of Leicester on FGMC in the diaspora. He has written and contributed to reports for Orchid Project, 28 Too Many, and Plan International, and his work was published in PLOS ONE last year. Dr. Osman Mahmoudi is a faculty member in psychology and counseling at Farhangian and University and director of the Hamras Counseling Center in Iran. He researches and writes on FGMC with particular attention to women's health and culturally sensitive approaches in Kurdish communities and the wider region. I'd also like to welcome Dr. Shabana Powell, who is CEO and founder of Shabana Powell Consulting, a global human rights firm providing training, technical assistance, and research at the intersections of gender-based violence, human trafficking, and systemic oppression. Her doctoral work created the Survivor Equity and Inclusion Framework, which aims to prevent the re-exploitation of lived experience experts. Her practice centers vicarious trauma, language justice, and ethical storytelling. And also Dr. Karen McDonnell, who is an associate professor and director of the Maternal and Child Health Program in the Department of Prevention and Community Health at the Milken Institute School of Public Health at George Washington University. She's a public health program evaluation and implementation specialist with more than 20 years working with community groups, public health agencies, and health systems locally and globally. And with that, I would like to start off with the first question. The question is, can you share with us some of the research you have been involved in connection to female genital cutting and how ethics, contexts, or even cultural nuances have intersected? I'd like to first go with Dr. Karen, then follow with Sean, and then Dr. Osman, and then Dr. Shabana. So I'll hand the floor over to you, Dr. Karen.
Thank you so much. And I think your opening really did set a really good stage for everything that we're going to talk about today. I have been very fortunate to work alongside everyone at SAHIA. And I also want to shout out to people who are here today from the US Network, the Global Women Peace Foundation, RACMA, and others for over a decade now in this area of research. Our body of research has been what you would call applied research or research in action. So we created our team by focusing on building on our collective strengths. And that is we all bring something special to the table, but our mission is the same. So we want to create survivor-centered and survivor-informed technical and training assistance. And our team has been involved in a number of efforts, including creating virtual online living toolkits for a variety of audiences, training current and future providers in FGMC, and how to implement trauma-informed care. So we use research to inform advocacy and policy development at multiple levels, and we support each other in everything that we do. And so getting to the why we're here today and how ethics and context and cultural nuance all intersect with each other, the answer is yes, they always do. We are working with people and we are delving and asking very intimate questions about their life experiences and asking about their life stories and asking people to trust us with what has happened in their lives. So one thing that we do in our collective efforts is we go into each of our projects with we're providing training and technical assistance, but be able to do that, we have to be sure that we are training ourselves in our best research and practice. And so we are very purposeful in how we are practicing our research. Before we start, we bring all of our voices together to the table and we anticipate challenges. And I'm in public health, and so we're all about prevention. So we anticipate challenges, we develop protocols on how to anticipate challenges where we might have ethical arguments, thinking about different cultural nuances. But first and foremost, we are very purposeful and intentional with our methods that we're using. We use something called mixed methods, in that we use numbers and surveys to tell us what's happening. But we also use words and pictures and stories, and that tells us the why, the how, the life, the context that informs the what. So in all of this and preparing ourselves before we even go out and collect or do any kind of data collection, we know that there's going to be challenges, but we've anticipated them and we're ready to be there to ensure that we have the coverage and that we support each other. And first and foremost, we know that we do not do this work on our own.
Thank you so much, Dr. Karen. I think we have Sean next if you'd like to build on that or share an ad.
Yeah, thanks, Huda. Thanks, Karen. A couple of thoughts just building on that. I also mostly do mixed methods work, a lot of secondary data analysis on top of that. And there's a couple of things where I think those three issues that you flagged up in the question intersect. I'll give you maybe two or three. I think there's an inherent challenge that we have where often, even as SEO and that we're both advocating for something and we're researching something. And the challenge in that, the researcher is there to observe and understand, whereas the advocate is taking a stand and sort of building from that stand. And when we collect data that doesn't support where we stand, what do we do with that? So there's an inherent challenge in that. Do we refute that? Do we downplay it? Do we do we only embrace the data that supports our stand? Yeah. So thinking that through, in those different ways, whether it's the secondary data that's telling us something, or whether it's the primary data, or whether it's the quant or the qual, is it are we skewing towards what we expected, what we wanted? I think that the second one that really came up in the work that I just finished doing across the US for the last couple of years is thinking about who to include, and probably more importantly, who not to include in the data set that I was working with. I specifically, I was doing a lot of secondary data work and then adding to that quant and qual surveys and interviews. And the Dawoodi Bohra community, for example, don't come out in the secondary data. There's no secondary data set, I can't find them in the census data, for example. And so I had to make a decision. Do I actually do the extra work of being able to quantify that community through other means and find a way to include them, or don't I do that? And then we know that there's FGM in the white community, in the indigenous, in the sort of American white community. How do I include that, or do I not include that? And so again, I had to make a decision there. Is that a separate study, or is that the same study? And in that case, I decided actually it's a separate study. So I did I did two studies. One that one that sort of, just within that community, and then one in the sort of the wider community. And those were ethical choices that I had to make, and very practical ones. And then just maybe a third quick example, in the end, talking to Karen's kind of public health framing, ultimately it's about who and where. And if we can get down to the who and where, we can start to think about where to provide services, where to equip medics, etc. But that means you have to kind of map it down to who and where, at the county level, at the neighborhood level, at the state level. And I was able to do that, but that then created a massive ethical challenge for me, because I now was sitting on a data set that ICE and Doge really would have loved to have their hands on. And so I actually made the decision not to make that publicly available. And I did make it available, but through multiple kind of two-factor authentication, and specifically no one who applies with a .gov email address has any access to that data set. So those sort of ethical contextual decisions, they weren't there when I did my ethics review, but they became reality by the time I was starting to publish results. So I had to make choices along the way.
Thank you so much for sharing that. That provides I think we've covered a lot when it comes to making ethical decisions, and that was really a good example. Thank you so much, Sean. I'd like to move forward with Dr. Osman and then Shabana. Dr. Shabana, sorry.
Thank you, Huda. It's a pleasure to be here with all of you today. Before I begin, I would like to apologize for not being able to turn on my camera due to the internet connection issue in Iran. The connection quality is not stable enough. I'm sorry for that. I would like to start by saying that I'm not an outsider to this topic. I live in Kurdish region of Iran, and FGM is a part of the culture I grew up in. My family and people close to me have experienced FGM and its effects. So for me, this is not a research topic. It is also something I have seen and experienced closely in my own social and cultural life. For more than 15 years, I have worked as a researcher, trainer, and family counselor on FGM. My research has included both quantitative and qualitative approaches. For example, we comparing the mental health and marital satisfaction of couples with and without FGM in Kermanshah, and also use qualitative methods to listen to women's lived experience and understand how FGM their lives. And recently, we worked on a positive psychology program to help survivors improve their self-esteem and body image. One important lesson from this research is that FGM cannot be understood only as a medical problem. It can affect mental health, marriage, sexuality, identity, body image, and quality of life. Therefore, research needs to bring together medical, psychological, social, and ethical perspective together. Being an insider has also created ethical challenge for me. It can make it easier to connect with the people in the community. Women, girls, or couple may feel more comfortable talking to someone who understands their language, culture, and values. But it also means I have a greater ethical responsibility. I must also protect their privacy, stay neutral, and make sure my own opinion and don't affect how I collect or understand the data. For me, cultural understanding is a part of whole research process. It starts with choosing the research question and continues through collecting data, understanding results, and deciding how to use the findings.
Thank you so much, Dr. Usman. And thank you for also sharing about your insider positionality and the responsibility that you hold and the ethics surrounding that. Thank you so much. And now I would like to pass it on to Dr. Shabana.
Hello, everyone. Good morning, good afternoon, good evening, depending where you are. I am so excited to be here with these amazing panelists. I'm a huge fan of SEO. I have been doing some research on the global intersections of FGMC and human trafficking. So my expertise is more on the human trafficking side of things. So today I will be talking about maybe some parallels in how we do research and approach the work from the human trafficking field versus the FGMC field, and also how we're all doing gender-based violence work, yet we don't always work together, which is what our research is focused on. In terms of ethics, context, cultural nuance, that has been embedded in our work, particularly because it's a global study. So lots of navigating different cultures, different languages. One thing that I think is essential is that you're addressing ethics from the beginning internally with your research team. So one thing that I loved in our work is we got really lucky, but we were really intentional about having a research team that shares values around intersectionality, being trauma informed, being survivor centered. And we also were very intentional about having individuals with lived experience of FGMC and of human trafficking on our research team. So that was kind of built into the design, built into how we treat one another on our research team, and then also naturally built into how the research project was designed. My doctoral research was on, as Dr. Huda mentioned, it was on lived experience expert inclusion in anti-trafficking work. And so we applied that framework, the survivor equity and inclusion framework, to this research study from the beginning. So what that looked like was intentionally being intersectional in our team and also in the participants, being trauma informed in our process, being strengths based, and then also ensuring everyone felt prepared to be in the space, was compensated for their time. So that was, I hate that we still have to say that, but we do. We should not be partnering with lived experience experts or survivors if we're not compensating them for their time. And also even the design of that compensation model. So is it accessible compensation? That's something we kind of were building as we were in different countries where a certain platform for being compensated does not work or isn't safe for someone. And so having options for someone to have choice. And then designing that model in partnership with survivors who can advise on their own experiences with being compensated and how to do that thoughtfully. Is there support so that we as researchers are not providing direct services to each other or to the participants in our study? Are we doing safety planning for our team? And are we doing safety planning also for the folks we're working with while maintaining that line of not being a service provider? Are we respecting people's expertise beyond their titles or their roles? And are we sharing power in our research team and then also with our participants? And what does that look like? And then I think just in terms of also the cross-sector study that we're doing, cross-training. So SEO is our FGMC partner on that. study, and they suggested cross-training from our anti-trafficking orgs with our FGMC orgs, so we have that baseline understanding, and that has been a really powerful intervention amongst the research. Partnerships with local organizations, so that if we're really trying to connect with survivors, we're going through trusted partners. One thing I found was also, I think because our team was survivor-led, in conversations with survivors, trust was just almost there at the beginning between partnering with trusted local orgs and being a survivor-led organization or team, and then building that into even just how we introduce ourselves. It was like people were just feeling safe and comfortable. And we also named that, although you feel safe and comfortable, let's talk about safety within that and what you want to share and what you don't want to share. So that brings me also to, I think, what a couple people were talking about around confidentiality and safety. So we had a lot of conversations around, well, what about AI? Should we use AI to, take a look at our qualitative study and help us? And we decided we just did not feel comfortable with that, given the safety concerns of the work that we're doing. Even the service providers putting themselves at risk in many ways to talk to us so that we could then share the findings they can't share. So that meant a lot more hours. And I was okay with that. And then it also meant even we had 2 to 3 people de-identifying our internal notes, just so that we're really, really careful that there's nothing that can be tied back to people. So I think all of that to say, being intentional in how you're treating one another on your team and how you design your team will really deeply impact how you're able to partner with the communities that you're serving. And the last piece is just, we also really wanted to not be extractive in our research approach. And one thing I found really powerful was even just asking, you're telling us all of this amazing information. What do you hope we could do with this? Like, if you could advocate for something, recommend like system-wide change, what would that look like? Can we at least, we can't promise we can make it happen, but can we at least document it for you and advocate with you for that change?
Thank you so much, Dr. Shabana. And thank you also for sharing points about de-identification and the non-use of AI. I think that's something really important. These are really important conversations to have. And also the thing you mentioned about compensation. Thank you for bringing that up too. And not being extractive, which sort of leads me to my next question. Surrounding decoloniality or the decolonial lens as well. Are there ethical principles or ways of knowing that extend beyond dominant Western research ethics frameworks? And if so, how have they informed your work? And I would like to start with Dr. Osman first, and then follow with Sean. And I'm happy to repeat the question if needed.
Yeah, Huda, please repeat again because I become disconnected for a minute.
Yes, Dr. Osman. So I'll repeat it. Are there ethical principles or ways of knowing that extend beyond dominant Western research ethics frameworks? And if so, how have they informed your work?
Yeah, thank you. Yes, definitely one important problem is that people often think all communities where FGM happen are the same. Much of the international literature focus on countries or communities such as African countries. Studies are very important, but there is a risk in applying their findings automatically to other communities. Communities such as Iranian Kurdistan or Iraqi Kurdistan are studied much less, and their culture, religious, and family setting can be very different from other countries. And another problem is seeing FGMC only as a women's issue. As a family counselor, I work on men, and I believe, and my research shows that, of course, men's like women effects from FGM-C. And sometimes a decision about a practice may also involve women, involve men and other family members. Our research shows that FGM can have a negative effect on husbands. In my research on honor-based violence, I found that men's beliefs and attitudes can be very important in understanding why some families continue this practice. So if we study only women, we may miss an important part of the social system that supports FGM. In another study on the psychosexual complication of FGM on couples, I found that men with a little knowledge about FGM and its psychosexual complication often blamed themselves for their wives' difficulty in reaching orgasm. This had a negative effect on their self-esteem and self-confidence. And in some cases, it even increased the desire for divorce and extramarital relationship because they found that discovered a problem in the relationship and try to find a solution in a wrong way for themselves. There is also a problem with the language researchers use. The words we choose can affect the relationship with participants. For example, the word mutilation is used in the international text because it shows how serious the practice is. But some women from affected communities like Kurdistan may not use the word for their own bodies and experience and use khatana or other words. If the language feels too judgmental, they may not feel comfortable speak openly with us. And another important risk is assuming that participants already know. Sometimes researcher or intervention programs thinks that survivors already understand the health risks of FGM. In my own field work, I found that is not always true. And the problem is that many people have a very little knowledge about FGM and its different complications.
Thank you so much, Dr. Osman, and thank you also for sharing about language and the preference of language when communicating with communities, whether there's a preference for female genital cutting or hutna or other such words. That's something I've also been deeply interested in when it comes to the semantics of hutna or khavs or female genital cutting. I will also pass this question on to Sean next, that are there ethical principles or ways of knowing that extend beyond dominant Western research ethics frameworks? And if so, how have they informed your work?
Thanks, Huda. Just bouncing off of Dr. Osman's point on language, and then I'll get back to the core of the question. But even in my research in the US, I ended up translating the survey tool that I did into 3 languages and then making multiple choices on which terminology I use. There were versions that had female circumcision in, there were versions that had cutting in, there were versions that had FGM in, and then one of the questions I built in early into the survey is the classic DHS sort of question around describing the procedure and have you ever heard of this? Yes. And then what do you call it in your community? And then my questionnaire then transposed all of the questions where I had FGM. I just put that term in. for the rest of the survey, so that people were then actually answering a survey based on their preferred terminology. And I think that the tech is there to do that, and I think it's really helpful to do that. Talking about just the sort of broader question around sort of Western ethical framing, and I don't want to be too rude about Western ethical framing, but let me be. I mean, it's very individualistic, and it's really designed to protect the institutions that are giving it out in the first place. So um, and the communities that we are researching are much more interdependent in their decision making, much more collective in their worldviews, and so and particularly in places like in Kurdistan, where Dr. Azman is researching, it's not only the questions, but it's being seen to being questioned by, who did you speak to? And what were you speaking about is part of part of this thing that you observed. And, I was involved in some disability research in Gaza with the University of Birmingham some years ago. And I mean, that was a very big part of our ethical kind of conversation, was that when working with the partner organizations on the ground, saying your Birmingham University ethics framework doesn't work here. You're asking kind of, is it safe? Well, we're in Gaza, nothing's safe. But that's not really the question. The question is, who are you seen to be talking to, and what, there's a whole different spin on what's needed than necessarily the questions that the IRB is asking. But going back to the individualistic thing, with my own research in the US, there was really two informed consents that I needed to get. Um, Firstly, I needed to get sort of informed consent from the community organizers and the community organizations that were opening their networks to me. Um, and then I needed to get informed consent from the actual participants of the study. Um, and that meant that there were times that I didn't get access because the the organization, the gateway said no, not that topic, or not you with that topic in this community. And that was the reality. And so, and I had both of those. I had one community that specifically said, yes, we'd love to, but not on that topic. And then another community that said, we'd love to on that topic, but not with you. And I was like, well, then I just don't get to that, my sample gets smaller as a result. And then, uh, Dr. Osman again sort of spoke to it, with his sort of insider positionality. I have the exact opposite. I'm the outsider in this, and so recognizing my own positionality in that, and that positionality is an advantage and a disadvantage in the exact same ways that it is for Dr. Azman. If I could build that trust, then I was that strange person on the other side of the planet that people could say things to. And that anonymity provided a space for sometimes a much more honest conversation than somebody would have had if the researcher was more like them or from their community. Um, on the other hand, it also meant that there were certain things that were not said to me. And then my positionality massively influences my understanding of all of that. And so really adopting a critical realist framing to recognize that who I am in this means that I only see this from my blinkered worldview, and recognizing that and mitigating that with a reflexive process. So for the 2 years of active research that I both the research design and then actual research that I did, I met every other week with community organizers from those communities to say, hey, this is what I'm thinking about, this is what I'm hearing, this is what I'm going to try and do. And I presented and we debated and I changed and I changed and I changed so that over those 2 years, what came out the end of it was not just my thought. And somebody asked in the chat, when when the community, when the survivors' perspective on this is different to the researchers, what do you do with that? And I think we have to be able to close that circle and get into dialogue and not only with our participants, but also with others that understand our participants from a different angle, and so that we can get to a more clear understanding of what's actually being said. So yeah, I think the Western frame doesn't help us in with much of what we're doing.
Thank you so much, Sean. That was very insightful. Also, you mentioned reflexivity and addressed that question. I think the question was if survivors disagree with researchers' interpretation of the findings, whose perspective should take precedence and why? And I was hoping that someone would answer that question. So thank you so much. I know that we're really time restrained, so I'll try and move on with the next question. And Before I do, I would still like to get some brief thoughts on this question from an institutional perspective. If you'd like to, Dr. Karen, perhaps elaborate, but more so from an institutional view.
Sure, because we've heard people talk about review boards. And so I think many of us have dealt with institutional review boards. I do where I am here. And they serve a purpose, but it's also up to us as researchers who engage in sort of global frameworks to inform the institutional review board members. And so I consider that a role that I need to take. And so one of the things that with the institutional review boards, so there's a couple things I want to touch on that we've talked about. So for those in the audience, when you're going to an institutional review board, the thing that is really important that we've all talked about is it takes time, right? Everyone here has really talked about their intentionality. It's purposeful. This is not something that you're going to do for a class project and get done in a week. Like, we need to, as instructors, as professors, as teachers, as community members, really get that message out. This is not something that you go in, get out. No, this is purposeful, it's intentional, it takes time, it takes relationships, as everybody has talked about, internal, external viewpoints, they're all so important. And so when you go into your institutional review board, is to really make sure that if let's say you're reviewing somebody's research protocol, look at the protocol. Look at it from these different lenses. Do they incorporate different perspectives? Think about the process. When you're talking about, as Sean, as you talked about, who's included, who's excluded, and why? What were those decision points? How are people's confidentiality being protected? How are you protecting the data? We talked about AI. Let me just put something out there. Don't put your interviews, don't put your surveys in AI. That goes out to the public. You have now violated people's confidentiality when you do that if it's not been de-identified. So you put that information out there. I love, Dr. Shabana, when you talked about sharing the power. So how is that exemplified in your what we call the IRB, Institutional Review Board protocols? How is that power being shared? Our review board also looks at how are you using the data. So what is your why? And I put that to everybody who's here today. Ask yourself, what is your why? Why are you doing this? What are you hoping to get out of this? I think, Shabana, you talked about how do participants want the research to be used, to not sit on a shelf, but to be used in a constructive manner. I also want to put one more thing out there. And I think, Sean, you talked about this up front, and that was about the IRB. In the US, one of the other protections that we can offer, you talked about this in terms of ICE and Doge. Quick story, when we first got a grant with our community partners, the first call that I got was from the FBI that they wanted to meet with me. yeah, everybody, I can see the looks. Nobody wants to have that. Like the FBI wants to meet with you. What I ended up doing, and I don't know if this is available in other contexts, was I went and got a certificate of confidentiality such that my records cannot be subpoenaed. And that added, it was an added step, and it took a couple months to get that. But my records, the records of the surveys, et cetera, in addition to what I had with the IRB, had that extra level of protection. And so that is something that was really important that we did. And I'll leave it at there in case anybody has any other questions.
Thank you so much, Dr. Karen, for sharing that, and especially how you placed emphasis on confidentiality and the process you went through. I think that really adds to what we're talking about. I'll move on to the next question. And the question is, how important is local language? Yes, I'm sorry. How important is local language in building trust, facilitating dialogue, and conducting ethical research on sensitive topics? And I would like to start with Dr. Shobana and then hand it over to Dr. Osman. And I can paste a question in the chat too, because someone requested or repeat it. So the question is, how important is local language in building trust, facilitating dialogue, and conducting ethical research on sensitive topics?
Yes, thank you, Dr. Huda. So it's very important, that if you think about, and if you've ever been to the doctor in another country where you are not speaking your language that you prefer, how difficult it is to get through all of that, or even to just say what you want to say. It has to go through all these filters in your mind as you're trying to express yourself. So we really value language access and also trauma-informed interpretation and translation. There's different ways that might look. I have found, especially with complex trauma like this, it's great if an interpreter can have an hour training on trauma-informed care, but that's not the same as years of work understanding the art of being trauma-informed, your body language, your tone, even the way that you might frame something, your understanding as a cultural broker between the researcher and the participant. So really partnering with, the way we do it is we partner with folks who have gender-based violence expertise and have the language skills. And if they don't, then we also like to offer training so that we can help train them up. If sometimes that happens when it's a more unique or less accessible language. And when we don't do that, we have found that does not work. So an example would be in this FGMC study that we're doing. I was working with a participant who was using an indigenous language. We had an interpreter. The interpreter we had was last minute, not able to make it, so they had a backup. And I could hear, because we use a mix of English sometimes if we speak other languages. And so the participant was sharing certain English words when they were expressing themselves. And then the interpreter was not relaying those words back to me. And so I would have to say in the interview, well, I heard the survivor or the participant say LGBTQ+, but I didn't hear it in the interpretation. Can you repeat it back to me? And my assessment was that that interpreter maybe wasn't comfortable with that language and so was excluding it, but it was essential to what this survivor was comfortable sharing and wanted to relay to me. Or, it was human trafficking and FGMC specific, so there's some more graphic terminology. Or, for example, I heard the survivor use the term pornography. None of that context was even relayed back to me. So I had to then ask again, can you share a little bit more? Can you repeat back the interpretation? I heard the survivor say pornography and I didn't hear that back. Thankfully, we only had that in one interview. All of our other ones, that has not happened, but it was such a reminder to me of why it's important that we do use trauma-informed interpreters and translators and what that means. And also even if who we selected is not available, canceling. So then we can actually reschedule and do this in a really thoughtful way. Thankfully, that survivor was also able to communicate in English, but that was not her preference, you know, and that's why we asked. And so that was really a downfall, I think, but a good lesson learned. And then the other piece I think on local language is just being so mindful of um, dual relationships and insular communities, that they're not connected to harm doers, that there is confidentiality, um, that they're actually translating or interpreting what you're saying. For example, I've been in situations where we're asking how someone needs help. The interpreter is saying, this is a religious or family issue. You shouldn't be talking to these people about it. Thankfully, I speak the language or my colleague speaks the language. That's not what was said. So really having trusted partners and then also being thoughtful about vicarious trauma for the interpreters and translators, because this is really sensitive and intense topics that we're covering. We don't know who has shared trauma, their own lived experiences. And so, are we also caring for the interpreters and translators that we're partnering with, or advocating for them to have that access to care if you're partnering with an organization rather than having that language access come through your organization?
Thank you so much, Dr. Shabana, for sharing that. Is there anything, Dr. Osman, that you would like to share or add to? You have mentioned the importance of language and trust and dialogue. So, is there anything you would like to add on how important local language is in building trust and facilitating dialogue?
Yeah, I fully agree with my friends in this regard, and I believe that local language is very important when we do a research on sensitive topics like FGMC. When I speak Kurdish or Persian with a woman and survivors, communication become more than just translating words, and I can understand cultural meanings, emotions, family relationship, and values that may be hard to express in another language. Uh, Also, local language can create a safe space for dialogue. Participants may feel more comfortable talking with someone who talk like themselves, and they know a researcher understand not only their words but also their cultural background and other things. One example from my book, we work on it, and it was very important, was to develop a care guide in Kurdish for local service provider in Iraqi Kurdistan. We prepared the material in Kurdish instead of English or other international language. Uh, in that case, a language was not a communication tools. It was connected to local education, professional practice, and behavior change. And also, we work with the local facilitators such as midwives, psychologists, and social workers. These people already know the community, so their involvement can build the trust and make the services better and more suitable for the local needs. Uh, um, and I believe that local language is not only about translation, it's about trust, about power, and it's help us move from doing a research on a community to doing research with a community.
Thank you so much, Dr. Osman. That was very insightful. And picking up from there, I'd also like to come back to emotions and trauma and violence. And more specifically, I'd like to ask Dr. Shabana, how do researchers care for themselves emotionally when working on topics involving trauma, violence, or difficult life experiences? And as you mentioned, your firm's practice centers on vicarious trauma, and you've also mentioned the framework. And what does this work do to the people doing it? And what does an ethical research design owe to its own team? I can repeat as well the question, but I hope I've consolidated all the points. Essentially, how do researchers care for themselves emotionally when working on topics involving trauma, violence, or difficult life experiences?
Yes, I think the way you framed it even already sets it up that it should not be on the researcher alone to care for themselves. It should also be in the institutional, like design, organizational approach to vicarious trauma prevention. I also want to note that where there may be vicarious trauma, there may also be vicarious resilience. So, vicarious trauma is where we have symptoms of trauma because we are bearing witness to so much trauma to the point where, like in the DSM-5 for mental health, you can be diagnosed with PTSD, post traumatic stress disorder, from having a job where you bear witness to so much trauma. I'm glad that exists because I think it helps normalize that this is what happens when our bodies and brains have a natural response to taking on that much exposure to trauma. But also on the flip side, if we have the care we deserve, we can have vicarious resilience, which is that there's studies that show that researchers, practitioners, because they see the power and resilience of the people they work with, they feel more powerful, more resilient themselves. And so I think this is where it's a responsibility of the individual, but also a responsibility of the organization working with them to create that environment where we're addressing and naming and ideally preventing vicarious trauma while also fostering vicarious resilience. I think key pieces to consider is just the intersectionality of lived experiences. Whether or not we disclose them in the workplace, we know research shows that many people doing gender-based violence work, there's been a few studies out now that it's about 50% or more, have our own experiences of gender-based violence, whether it was our own experience or something we witnessed as a child. So that shared trauma or dual burden may likely be present whether or not your team is telling you it's present. And they should not have to, it wouldn't be ethical to ask for them to share that with you, but are you building in a system where that is at least like not assumed, but it's possible. And so if we're creating safety for people who have that shared lived experience, then that's creating safety for everyone, anyways. And also, you can have vicarious trauma if you did not experience that form of violence yourself. I've also noticed it particularly in our FGMC work where there's intersections with religious trauma or racial trauma or even like trauma within your cultural community. What you're doing as a researcher, you may not realize it's going to tap into that piece of yourself, of maybe something that's happened in the past that you thought was fine, but actually is coming back up. And also just the graphic details. For example, our team specializes in trafficking, and a lot of our team members specifically specialize in sex trafficking. But there's different types of graphic details that come up when you're doing FGMC work. And so we had to prepare for that. And then also just create space to debrief that in healthy, trauma-informed boundaried ways at work. So individual check-ins in your individual supervision, utilizing a trauma-informed supervision approach, group check-ins being baked into your process, also access to outside therapy with like outside clinicians, if that's something your agency can offer, if not having a resource list where people can have access to those services. And then also just making sure that you're screening internally as you're even bringing people onto the team. What is your self-care plan? If someone tells you, I don't have one, I don't need one, this work doesn't bother me, it's a bit of a red flag. Like, ooh, because we should be safety planning, and that's self-care planning is safety planning. And then for the organization, it's also funding structured vicarious trauma prevention, putting that as a budget item rather than waiting till harm happens. And the reason I say that is because if we don't care for our researchers and our staff, then we're seeing things like suicidal ideation, we're seeing substance use, we're seeing like harm in their like just relationships, declines in their relationships, depression, all of these things if we're not caring for our staff. And then on the individual side, what that can look like is collective care. So leaning on your networks of support. Also, just not being mindful not to trauma dump, meaning like sharing graphic details, sometimes in staffings or with coworkers, or like just giving all the graphic details to the next person. That's totally fine. I'm a clinician, I'm a mental health clinician. Totally fine to your therapist. But we've seen that it causes harm in a group setting, or to folks who don't have those boundaries in place in your relationship, where now I'm actually sharing all these details, and then you're sharing your details, and we're actually feeling more vicarious trauma. So can we talk about how it makes us feel without talking about the specific details that happened? And I always say therapy, vicarious trauma is such a valid reason to come into therapy. If someone came to see me or one of my colleagues and said, the only thing I have going on is my work is really challenging and it's impacting me, can I talk about that? That is so valid. And that deserves support. So we encourage folks, if you have access to that, seeing a culturally responsive clinician can also be really wonderful. And if organizations can pay for that, even better.
Thank you so much, Dr. Shabana, for bringing up those points of collective care, safety planning, check-ins, and also access to outside therapy. Those are very important points. I'd also like to extend this question, perhaps if there are a couple of things that Dr. Osama would like to add as a clinician as well, regarding this question on how do researchers actually, I'm sorry, I think, yeah, how do researchers care for themselves emotionally when working on topics involving trauma, violence, or difficult life experiences? But more so as a clinician, I would like to bring that question to Dr. Osman. If there's anything to add.
Thank you. As a clinical and a researcher, I think emotional self-care is an. Do you hear me?
Yes, we
Ah,
can hear you
yes, thank
clear.
you. Yes, I think emotional self-care is an important part of ethical research. When we listen to experience of trauma or FGM, we can sometimes be affected by what we hear. Some researcher found should not wait until they feel overwhelmed. They should have a regular check in supervision and opportunities to talk about difficult experience with trusted psychologists. For example, I can talk with our friends in this panel, Lisbon, like, and it's very important for self-care. I also think it's important to have a clear professional boundaries. We need to be compassionate and supportive, but we are not always able to solve every problem that clients bring to us. In my clinical experience, having a clear referral pathway is very important, and I think it's very important to pay attention to this factor in our works. Another important point is collective care. Researchers should not feel that they have to manage difficult experience alone. I think a work team is very important, and sometimes work alone can damage us if we try to work on a specific subject like FGM or a special in a region with its limitation. We experience this in Kurdistan in some places when we try to work alone on FGM. And finally, researchers need to recognize their own limits. Sometimes taking a break, changing the pace of interview, or even stopping interview is ethical things to do. Caring of research is not separate from the research ethics, and it's a important part of it.
Thank you so much, Dr. Osman, especially the last thing you said, that caring for the researcher is not separate from research ethics itself. I think that's what yourself and Dr. Shabana have been conveying. And I also I'm glad to hear care and compassion, also collective care, come through these conversations, and just so grateful to be here and be learning from all of you. The next question is something I'm also very personally interested in because I'm a qualitative researcher. So I will ask Sean this question. How can quantitative approaches to research amplify or dilute cultural context and narratives?
Thanks, Huda. Again, I want to just jump off of what Shabana and Osman said before I go there. A bunch of the people on the webinar today introduced themselves as PhD students or master students or independent researchers, and so that organizational care piece is often not necessarily there. And I found that as a PhD, and I think it's just we all of this stuff applies. We just have to do it ourselves. And being able to, just find the budget somewhere to get yourself into some counseling, beg and borrow access, because these things, the stories are not helpful for us, and if we're carrying them around, they do trigger all of our other trauma. So, um, my wife would say to me, "When are you seeing your shrink again?" Yeah, I would know that it would be time. On the quant side, and particularly the secondary data side of it, my research is often looking at big data sets, mixed DHS data sets, census data sets, that millions of records, and then trying to extrapolate out of that some kind of sense to what it's saying. Let me start by the negative. I mean, many of you who are familiar with the US research on FGM would know the CDC study that Goldberg did in 2016, that the 513,000, and the way that Goldberg reported that in that study is 513,000 women and girls who were at risk of FGM or its consequences. So that's the exact word, at risk of FGM or its consequences. That then got picked up in the British Medical Journal and under a headline by McCarthy in 2016 that read 500,000 women and girls in the United States at risk of genital mutilation. So in other words, how it was reported, 513,000 at risk or its consequences, was interpreted as 500,000 girls at risk. Now, we know that of that 513,000, probably 500,000 were already living with FGM and therefore weren't at risk. They were in the and consequences part of that equation. But the way it was interpreted was to put that whole 500,000 into the risk category. Now, what that then does for a legislator or a or a or a criminal justice person is it says, oh my goodness, we've got this massive crisis of child protection. We need to go draconian and stop everybody at the border. And, it drives a prosecution, it drives a protection agenda rather than driving a provision of services, a prevention agenda. And so the numbers can do exactly what we don't want them to do, which is, they can tell the wrong story. And so that becomes the really important thing with quantitative data, is that we need to interpret and communicate it in a way that is understood by the community and by the stakeholders to really be reflective of what the data is saying. If we do that, the data can be super helpful in its framing. So, in my latest study in the US, I've adopted the two terms, living with and at risk. And my extrapolation then says, oh, I come up with broadly the same number, sort of 475,000 in total, but I kind of report it as 463,000 at risk, living with, and 11,000 at risk. And that changes the narrative, that it immediately says this is a healthcare provision issue, not a child protection issue. And so the framing of the numbers is important. Let me give you a couple of other examples in that. Sort of which data to include, which and how to understand that data, again, needs to be triangulated with with the community. The the theoretical framing through which you're understanding the data needs to be really thought through. And if you're understanding it in this very sort of individualistic way, you're going to miss the nuance of a more collectivist community where FGM is happening. And so you're going to misinterpret things. The modeling that we then build these projections on, again, needs to be informed by the qualitative data. So again, in Europe, the broad formula for doing these sort of big national estimations is to take the census data from the country, the prevalence data from the country of origin, and then multiply those two together and then mitigate it by some kind of a factor to account for migration and acculturation. And in the EU, they do at times 0.5. That's it, which clearly is wrong. I mean, that's the only thing we can say about that, is that whatever the number that comes out of the back of that is wrong. When in my own study in the US on the impact of migration and acculturation, I came up with 5 or 6 different factors that are all sitting inside that times 0.5 and are fundamentally different to 0.5, and are very individualistic, or individual in terms of what age did this person migrate, what age does FGM normally happen within their community, where do they live, what is their neighborhood like, where did they go to school, what exposure have they had to mitigate, to community education, etc., etc. So there's this whole plethora of sort of frames that are impacting the modeling, but you're not going to pick that up if you're not actually doing the qualitative work, if you're not actually speaking to survivors and trying to understand how do these dynamics actually work in your communities, and then try to model that in the modeling, because at the end of the day, it's just modeling. So you know, um, I mean, even the census data, or our world in numbers or whatever, and and there's 17,426. It's just a model. There aren't actually 426. And in my data set, I had a call with my data set suggested that there were some impacted communities living in Hawaii, because that's what the math said. And then I had a call from a senator in Hawaii saying, I want to know who those 12 people are. It's like I don't know, there aren't 12 people. There's just a small number. It's an insignificantly small number of people. And so, compared to the tens of thousands somewhere else. So, I think we've got to read all of this with a bit of pinch of salt. And maybe just an example from the UK. We have mandatory reporting here in the UK, where anybody that intersects with the health system and is, noted to have had FGM needs to be sort of flagged up in the system. And then those numbers are published every quarter. And when those numbers will come out, there's 86,000 people, and then they break it down by sort of local authority. But again, the way that the media then picks up is, there might be 26 in a community one year, and then there's 45 the next year. And they're like, the numbers have doubled in our communities. Like, no, they haven't. It's just more women have actually turned up at the health service who were already cut long before the first number was published. But these women are now actually seeking help. They're not new cases. And so, it's just understanding the numbers and really trying to communicate them clearly, because statistics lie very well.
Thank you so much for this, Sean. I think this is very helpful for me to understand, because I'm I'm really afraid of quantitative data. And just this year, I took up R. So yeah, I was like, this is going to be the year that I learn about quant and explore quantitative. So thank you. What I take away from this, and I'm sure many other ECRs and early career researchers will take away, is the framing of numbers is important. And also adding that context, speaking to survivors is also important, what I've gathered. And also you mentioned a pinch of salt. So those are a few things that I've noted down for my own notes, and I'm sure people are noting them down too. I'll move on to the next question. And this is for Dr. Karen. What recommendations would you offer to ethics committees and institutional review boards when reviewing FGMC research proposals?
Thanks. And I know we touched on this before. And one of the things, so in addition to what was brought up before, what I would also add is how are you going to communicate the results? I think that needs to be paid attention to. We're talking about framing. And so part of how we frame things is also how we feedback. How are we going to take what we learn and communicate and disseminate that? So we talk about we're going to have a report. Well, that's not enough anymore, right? Just having a report. We talk about these different audiences that we're working with. So I think we have to also think through the different types of communication and feedback that we're going to have with each of these audiences. We're going to have to be very purposeful in generating different types of reports. One for maybe for the survivors, one for healthcare providers, one for advocates. Again, that gives each audience, hopefully in a safe space that is created, to then feedback. So if there is disagreements, we can have those discussions and understand what are we disagreeing about and why. Are we framing this correctly? And when we're putting this message out, as Sean just talked about, what we can do with glass half empty, glass half full, depending on how you frame it. And it just brought something back to me as well in terms of communication. We've been talking a lot today about what we say, but we also have to be very careful in doing research and in how we're training others to do research. It's not just our words. We also, what we found in working and talking with survivors and different communities is they're very attuned to our nonverbal cues. So we also, not just are we using the right words, but what does our facial expression look like? Because that can also hamper the interaction, the ethics, the cultural, the nuances. So I want to put that also out there. So when we're talking about framing and communication, it's not just the words that are coming out of our mouth, it is how we're acting, our body positions, our respect that we are demonstrating to our audiences.
Thank you so much, Dr. Karen. And I think the last point that you mentioned, it's so pertinent about the body language, the facial expressions as well, how we're receiving what is being said and how we're responding to it as well. That really stood out to me. And thank you for reiterating that and reminding us all of that. Because across many cultures, there are different ways that things are interpreted. Sometimes eye contact is considered a sign of a respect, while in other cultures, not making eye contact is it's part of the norm. So thank you so much for also mentioning that and pointing that out. It's a good way for me to also revise all these points. So I will move on to what might be our closing round and concluding question. And this is to all our distinguished panelists that what advice would you give emerging researchers seeking to navigate ethics review processes for sensitive topics? I think Dr. Karen has shared some really golden nuggets with us as well regarding IRB, regarding ethics boards, and it can be a very scary process for many. So if there's anything to add, Dr. Karen, and then we'll move on with Dr. Osman, Dr. Shabana, and then we'll move on to Sean.
Sure. I mean, I think what some of the things that we've been talking about with the IRB is think about who's on your team. Look at the questions. How are the questions worded? Are they demonstrating a bias that you may not even be cognizant of? what are the recruitment protocols? Are there any sort of manipulations? What are the safety provisions? How is confidentiality assured? Is there a mechanism for participants to ask questions and to drop out without repercussions? And also, as we talked about before, how is shared decision-making and power structures implemented in the different protocols? One way that we do this is, of course, we have survivors look at and be part of the team, look at the protocol, they're part of the team that's developing this, but you yourself as a researcher should be able to put your different lenses on and look at this from different perspectives. And that's before this gets implemented. Regardless of whether or not it's an institution that's covering themselves, you as a researcher have to have your own morality and your own ethics that you are going to abide by. And I think more than any IRB board, that's the most important point.
Thank you, Dr. Karen, especially the last point that you mentioned about us having our own moral compass as well as researchers. That really guides us through the research and even after the research because it's an ongoing process. Next, I would like to forward this question to Dr. Osman as well. I can repeat the question as well, Dr. Osman. What advice would you give emerging researchers seeking to navigate ethics review processes for sensitive topics?
Do you hear me, Huda?
Yes, Dr. Osman, I can hear you. We can hear you very clearly.
Yeah. Thank you. My advice in this regard is don't rush the trust. I think with sensitive topics like FGM, trust take a time and it's not happen in a short time. I encourage researcher to work with the local professionals such as social workers, psychologists, midwives, and community leaders. It's a very important factor. They should be a part of our research, and without them, we can face the many problems. I also recommend avoiding only collecting data or publishing it. I think it's very important that we use our data in community. As a researcher for many years, I have a good experience in this regard. All time we try to change our publication in an applicable protocol for the people and use a local language in our research and our publication. And it's really important for our work because we want to stop FGM. We want to work this phenomena to remove it from our community. Finally, ethics is not only about getting approval, it is about relationship, confidentiality, safety, and accountability. So my message is simple. Follow the ethical rules, but also listen to community, listen to religious leaders, listen to people around you, and it's need a very psychological and good personality for manage this important issue. Thank you.
Thank you so much, Dr. Osman, and thank you also for being with us despite the connection issues. We are also grateful for you to be here. And thank you for also highlighting that we should use our data in community, which is an important point, and that local language and building relationships should also take priority. I will forward this question to Dr. Shabana now.
Sure, I echo Dr. McDonald and Dr. Osman. Just prioritizing, for me, it's about value. So I'm always going to prioritize safety over publication. And having a team who feels the same way. And then also, can we be creative and do both? Are there things that can be published in safe ways? And then also having that feedback loop to participants. So are there different reports, a more academic one, a more community facing one? And for the language access side, if we conducted any of our research in other languages, those reports should be translated into those languages so participants can actually read them, engage with them, and share them with their communities. And then the last piece for ethics review and even in general is, are we also being mindful of vicarious trauma for our admin staff, if we are so lucky to have admin staff, the people answering the phones, responding to emails, maybe even helping submit your ethics review applications. Because if they're seeing any of this content, even if they're not deep into the details of it, it can be impacting them. It likely is. And is that included in our vicarious trauma response and prevention work?
Thank you so much, Dr. Shabana, and especially thank you for the last point about also caring for admin staff as well, which is so important, and also safety over publication. I think this should be something said more often, especially within higher education and academia, that safety over publication. And lastly, I'd like to forward the question to Sean.
Thanks, Huda. I mean, I'm going to say the same thing that everybody said. I mean, let me use a metaphor. I think it's not about passing the driving test. It's about being a better driver. Um, and I think if we kind of approach the ethic review in the same way, that it's not just about getting that ethics review number so you can go and do your thing, but it's actually about being the better researcher. And if you are the better researcher, the ethics thing will just take care of itself in a sense, because you would have designed all of those things into the design. And if you haven't, and the ethics review board is calling you out on some stuff, well, that's going to make you a better researcher in the end. And so, that don't see it as another admin hoop jump, but see it as a way to make you uh, a more responsible, a better researcher.
Thank you so much, Sean. I think that also adds to the process of reflexivity for researchers, reviewing, refining, revisiting as well. Sometimes it can lead to sleepless nights as well. Am I doing the right thing? Especially what I think Dr. Karen mentioned with regard to the moral compass. It's like I've had a lot of sleepless nights. But I think that's also good because it does better one as a person, as a researcher, and just as a human being. I am so grateful to share this space with all of you and to be in your presence. And thank you for all these answers and golden nuggets all of you have shared and for your time. There are resources that have been mentioned in the chat for everyone to have a look at. And I think I will be passing this on to Olivia, or I think, am I?
Yes.
Okay.
Thank you so
I will
much
pass
for
to this.
moderating, Huda, and I've really appreciated the kind of conversation that you've been facilitating and highlights of the responses that our panelists have shared as well. And I know that we are just a bit over time, so I did want to release our closing poll. I'm excited to see that we've had such an active chat and questions and resources kind of going in and out of the conversation. So as I mentioned at the start of the day, we will make sure to compile all of the resources shared and a recording of today's session to send to all of our attendees and folks who registered and maybe were not able to attend live. So I just want to reemphasize that and give folks a minute to participate in the closing poll if you have the time. And then as that is going on, I just want to again offer a really great um, congratulations and round of applause to our panelists for joining today and sharing so much of your knowledge and experience with us. And thank all of our attendees as well on behalf of SAO for participating in today's conversation. We are really hoping that this is the start of an ongoing conversation. I know that there are some questions that we were not able to address live, and we are hoping to gain more insights onto where we can take the conversation next. So thank you all for your participation and joining today. And for our panelists, I hope you've gotten a chance to see the chat. A lot of thank yous and positive reactions so far.
I love the engagement. These questions are fantastic.
I was wondering, Olivia, I have a few colleagues in Australia who wanted to watch the recording, so will that be automated and sent? Oh,
Oh, it won't be automated because I also just want to include some of the resources that were spoken about as well. But it will be sent to anyone who is registered, even if they registered a little bit after the event started.
okay, thanks.
All right, it looks like folks are signing off, so I'm going to stop sharing. And Maria, are we okay to